All right, so now that we've talked about airway and the importance of having a patent airway, let's talk about respiration and artificial ventilation, the process of air going in and out. So, we'll talk about the physiology and pathophysiology of breathing and what respiration is, positive pressure ventilation, and us actually causing the ventilations or working to create adequate chest rise and rate, oxygen therapy, special considerations, and then we'll talk about advanced airway devices that you can help with, or some of them that you can even use in your system's protocols. Physiology and pathophysiology. Ventilation is the process of moving air into and out of the chest. When we inhale, naturally it is an active process. Our muscles are contracting and working. It's the muscles between our ribs, what they call intercostal muscles, contract, and that lifts the ribs outward. The diaphragm contracts, and that creates more space in the chest cavity. The lungs are attached to the ribs by those linings I told you about, the pleural linings, the visceral and parietal pleura. They're connected together with a little bit of fluid, but they create a almost like a seal, or they're stuck together. So as the muscles expand, the size of the chest increases, and now negative pressure pulls air into the lungs. Almost like a syringe. When you pull the plunger on the syringe, air goes into the syringe. Exhalation is a passive process where the muscles relax and the size of the chest cavity naturally decreases and relaxes. Positive pressure is created, and then air is now pushed out of the body. Tidal volume, that's the amount of air moved in one breath. On the average adult, it's about 500 milliliters of air in one breath. Minute volume is tidal volume times rate. So the amount of air we breathe in one breath times how fast we're breathing in a minute is minute volume. Dead air space is the air moved in ventilation, but it's not actually reaching the alveoli. It's in the bronchioles and the air passages. So it never gets down to the alveoli and oxygen exchange taking place. The alveolar ventilation is the air that actually reached the alveoli and that's utilized in the exchange of oxygen and carbon dioxide. Diffusion is what has to happen in order for the oxygen to move across the membranes. It's the movement of gases, in this case oxygen and carbon dioxide, from an area of higher concentration to an area of lower concentration. So they're moved across the membrane because there's less oxygen in the capillaries that are surrounding the alveoli, so that oxygen in the alveoli move over into it so that it equalizes out. Same with carbon dioxide. Carbon dioxide moves over into the alveoli, and that's where we exhale it because there's a lesser concentration of carbon dioxide in there. It's constantly replacing that. External respiration is the diffusion of oxygen and carbon dioxide between the alveoli and the circulating blood. So that's what's happening in the alveoli. Internal respiration is that exchange taking place between the blood and the cells that they're going to throughout the body. So we have respiration taking place in the lungs, in the alveoli, and we also have respiration process taking place at the cell level where the capillaries surround the cells. And then they're giving off their oxygen, picking up the carbon dioxide. Cellular respiration then is oxygen from blood diffused into the cell and the carbon dioxide diffused from the cell into the blood. The mechanics of breathing can be disrupted. Gas exchange can be interrupted, or you can have circulation issues. All of these can be components in the cardiopulmonary system not working and the exchange not happening. Respiration. You need to know the difference between adequate and inadequate breathing, because you need to know when you can step in and help somebody breathe. Breathing is also a process that the brain controls. The brain and the body cells need a steady supply of oxygen. If they don't get it, they're in what's called hypoxia, a low oxygen level in the cells. Carbon dioxide needs to be continually removed. If not, a condition called hypercapnia or high carbon dioxide level exists. So you need to assess how well the cardiopulmonary system is accomplishing that task it has of bringing oxygen in and removing the carbon dioxide. The body tries to compensate for hypoxia or hypercapnia, and you'll see signs and symptoms of somebody having compensation, so you can predict whether or not they're compensating and having hypoxia. Some of these signs you're going to see are shortness of breath, increased respiratory rate and depth, and an increased heart rate. So the body's compensating because it's trying to breathe faster and in some cases breathe deeper or increase the heart rate to circulate the blood and oxygen around faster. Early on, these steps of adjustment can meet the needs of the body despite the fact that it's a little bit challenged respiratory-wise. But as the problem persists and progresses, then the person will be moved into what's called a respiratory distress. And this is where the body is really compensating for that respiratory challenge and still trying to meet the metabolic needs. When they're breathing inadequately, that means that they can't keep up with the need. So they're really having a hard time compensating. The body isn't able to compensate. It's too great for the body's mechanisms. This is also known as respiratory failure. So when there's respiratory difficulty, they'll have respiratory distress, and that's when the body is trying to compensate and make up for it. But when it can't keep up, it'll move into what's called respiratory failure. You need to recognize respiratory failure because the next step is respiratory arrest. So, respiratory distress, they're using their accessory muscles and they're having increased work of breathing. Might be a severe or prolonged respiratory distress, but it'll progress eventually to respiratory failure and inadequate ventilation, and the body can't keep up, and then they're going to have altered level of consciousness. They're going to be more tired, shallow ventilations, and they're not breathing adequately. The next step is respiratory arrest. So, when you first assess your patient, you're going to check and make sure their airway is open, and then you're going to look at their breathing. If they're breathing adequately, they'll have normal mental status. They'll be alert and oriented. They'll have normal pulse ox readings. Their skin color is going to be normal, showing that they're perfusing okay. If they're not breathing adequately, they might not have adequate chest movement, or it's uneven, or unequal. They might be using their abdomen more to breathe. No air can be felt or heard at the nose or mouth. Breath sounds are diminished or absent. There will be noisy breathing, either wheezing, crowing, stridor, gurgling, or gasping while they're breathing. The rate of breathing might be too rapid or too slow, generally above 30 or less than 10. The breathing is very shallow, or it could be very deep, or it can be very labored. You can see they're working real hard to breathe. You'll see cyanosis. Cyanosis is the blueness of the skin color from inadequate oxygenation. Inspirations or expirations are prolonged. So as they breathe in, they're taking longer to breathe in, or as they breathe out, they're taking longer. You might see retractions, intercostal muscles working really hard between the ribs, and nasal flaring in kids. And they may have a low oxygen saturation when the body is unable to keep up. Hypoxia. Some major causes of hypoxia. A patient trapped in a fire. A patient having emphysema, not getting enough oxygen in. A patient overdoses on a drug that has a depressing effect on the respiratory system. A narcotic overdose, for instance. A patient has a heart attack. That all can cause hypoxia. Inadequate breathing. What do you want to do for it? Well, you want to provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. So if they're breathing too fast and it's not adequate, or too slow and it's not adequate, then they need assistance. You're going to take a bag valve mask out and help them breathe. And you're going to hook it up to supplemental oxygen. If the patient is breathing, hook them up to oxygen so they can get extra oxygen into their system. So when to intervene? That's always the $100,000 question. When are you going to help this person? A lot of times, if they're in respiratory failure, the patients are going to be breathing and they're going to be conscious. If they are in respiratory failure, they're not going to be breathing adequately. So identify the adequacy of breathing. If it's inadequate, immediately intervene. So what signs might identify the need to intervene in a breathing treatment? Anytime you see altered mental status, or their breathing is too fast or too slow to get adequate depth and oxygenation. If their blood pressure is dropping, altered mental status, you are in respiratory failure. They're not keeping up. Their body is tiring. So, positive pressure ventilation and helping somebody to breathe with a bag valve mask. Positive pressure ventilation is forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. It's basically using force exactly opposite of how the body normally draws air into the lungs, because we breathe, all of us breathe through negative pressure. We're actually forcing air in with a bag valve mask. So, negative side effects of positive pressure ventilation. You could actually decrease the cardiac output and drop the blood pressure. You can cause gastric distension or excess oxygen or air in the stomach, which will put pressure against the lungs and make it harder to ventilate, and it'll also cause vomiting. Hyperventilation, breathing too fast for them, and that can cause problems because it lowers the carbon dioxide levels in the blood. So, do not ventilate a patient who's vomiting or has vomit in the airway. Positive pressure ventilation will force that vomit into the patient's lungs. Suction them first. Watch the chest rise and fall with each ventilation. Make sure you're getting an adequate chest rise. And then ensure the rate of ventilation is sufficient. You don't have to ventilate somebody really fast. We only breathe 12 to 20 times a minute. And that's when the oxygen in the air is 21%. You're going to ventilate somebody at about 12 times a minute with extra oxygen attached to your bag valve mask. So you'll be giving them 100% oxygen. So they don't need to breathe at 20 times a minute or even more. Carefully assess the adequacy of the respiration. Explain the procedure to the patient if they are somewhat alert. If they're breathing 34 times a minute, you want to help them to breathe by giving them a little bit more depth. So you're going to put that bag valve mask on them and try to ventilate them when they breathe in. So explain this to them. Talk to them. This is going to freak them out a little bit. Place the mask over the patient's mouth and nose. When you seal the mask on the patient's face, squeeze the bag when the patient inhales. CPAP and BiPAP. These form a non-invasive positive pressure ventilation. So this keeps those airways open with just a little bit of extra air pressure put in there. CPAP is called continuous positive airway pressure, and BiPAP is biphasic positive airway pressure. So CPAP is a continual pressure on those airways, so you have to have a good mask. It's somewhat like wearing an SCBA. And BiPAP is pressure when they breathe in, keeping that pressure open, but also applies a little bit of pressure as they breathe out. Biphasic, in and out. You can also do mouth-to-mask ventilation. This is performed using a pocket face mask. So you got a pocket mask on them and you're breathing in with your mouth over it. Whatever you do, you definitely want to use personal protective equipment to protect you from any diseases. When to use mouth-to-mask ventilation? On a patient without suspected spine injury, because you're going to use the head tilt chin lift, you want to have the EMT at the top of the patient's head. Position yourself directly above the patient's head. Apply the mask to the patient. Place your thumbs over the top of the mask, your index fingers over the bottom of the mask, and the rest of your fingers under the jaw. And then you're going to lift the jaw to the mask as you tilt the patient's head back and place remaining fingers under the angle of the jaw. When you lift the jaw, squeeze the mask with your thumbs to achieve a seal, and then give breath in a one-way valve and watch for the chest to rise. Use only a pocket mask with a one-way valve. You don't want that vomit to come back into your mouth. You can have a handheld ventilation device. The bag valve mask is this. It eliminates you having to put your mouth onto a mask. And it's used to ventilate a non-breathing patient or a patient in respiratory failure. It's not as effective as mouth to mask, realistically, because it's really hard to create a seal with your hands and one hand and squeeze the bag. The advantage with the mouth to mask is that you can use both hands and then use your mouth to ventilate. Here's a bag valve mask. They come in different sizes. The adult mask, you can squeeze anywhere from 750 to 1,000 milliliters of air into an adult patient when you squeeze that bag. But they don't need that much for chest rise. The average adult only breathes in about 500 milliliters of air in one breath. So you don't need to empty that entire bag into them to get adequate chest rise. Standard features of bag valve mask. They have a safe self-refilling shell that is easily cleaned and sterilized. Most of them are disposable now, though. There's a non-jam valve that allows an oxygen inlet flow of 15 liters per minute. So when you hook up that oxygen to the bag valve mask, you will be giving a ventilation with 100% oxygen in there, as opposed to them breathing on their own with 21% oxygen in the air around them. And it has a non-rebreathing valve so that they can exhale and that the CO2 comes out and isn't rebreathed back in. The mechanics of using a bag valve mask. There's a supply of 15 liters per minute of oxygen attached, and then it enters the reservoir. And then when you squeeze it, the air inlet closes and oxygen is delivered directly to the patient, 100% of it. When released, then their passive expiration, when they breathe out and relax, then they're actually exhaling their CO2. To rescue a bag valve mask, if there's no trauma suspected. Now, to rescue a bag valve mask is actually preferred over one rescuer bag valve mask, but it's still not as good as doing the mouth to mask. This to rescue bag valve mask is the recommendation of American Heart Association, because the most difficult part of ventilating somebody with a bag valve mask is trying to keep that seal on the mask. So if you have one person holding the mask to the patient and maintaining the seal, then the other rescuer can squeeze the bag. So, open the airway with the head tilt chin lift. Select a correct valve mask size, either adult, child, or infant. Kneel at the patient's head, position thumbs over the top half of the mask, index fingers over the bottom half. Place the apex of the triangular mask over the bridge of the nose, and lower the mask over the mouth and upper chin. Use the middle ring and little fingers to bring the jaws up into the mask. Maintain that position. And now the second rescuer connects and squeezes the bag. The second rescuer releases the bag and the patient exhales on our own. So, if there's trauma suspected, then you use the jaw thrust maneuver instead of the head tilt chin lift. Open the airway using the jaw thrust. Select the correct bag valve mask size. Kneel at the patient's head. Place the thumb sides of your hands along the mask to hold it firmly on the patient's face. Use remaining fingers to bring the jaw up toward the mask without tilting head or neck. The second rescuer releases the bag and the patient exhales passively. And here's an example of two-person bag valve mask while stabilizing the head and neck. You see where they're putting their fingers underneath the jaw there and bringing the jaw forward to keep the tongue off the back of the throat? That's the jaw thrust. The only difference is they're not got their thumbs on the cheek, they got them on the mask, creating a seal. One rescue bag valve mask. Open the airway, select a correct size, form a C around the ventilation port with the thumb and index finger. Use middle and little fingers to hold the jaw to the mask. Squeeze the bag, release the bag on pressure on bag, and let the patient exhale on their own. If the chest doesn't rise and fall when you're ventilating somebody with a BVM, you should reposition the head. Might be the tongue is blocking the airway. Check for escape of air around the mask. Maybe the mask isn't sealed. Check for an airway obstruction or an obstruction in the bag valve mask, or use a different method to ventilate them. If somebody has a stoma from a tracheostomy, these can get clear mucus plugs or secretions and can block the airway. There's no need to move the neck or head at all on this. Leave the head and neck in the neutral position. Use a pediatric size mask to establish the seal around the stoma. An adult mask is going to be too big. You can ventilate at an appropriate rate for the patient's age, depending on what their ventilations are. 12 to 20 for an adult. For a child, it's 15 to 30, and for an infant, it's 25 to 50. That's how many times a minute they would breathe. If you're unable to artificially ventilate through the stoma, you can seal the stoma and attempt artificial ventilation through the mouth and nose. So, a flow-restricted oxygen-powered ventilation device is also called a manually triggered ventilation device, or years ago they used to call it a demand valve. It uses oxygen under pressure to deliver artificial ventilation through a mask placed over the patient's head. These deliver higher pressure, so you want to be sure that it has a relief valve so that too much pressure isn't put into the airway. You can only use it on adults. You need to follow the same procedures for mask seal as for bag valve mask, and you trigger the device or you press the button until the chest rises. No more, or you're going to have excessive pressures in the airway. So here is a flow restricted device. There's a little lever that he's got his finger on that he's going to compress that when he's going to ventilate. It looks like it's a little bit easier than a bag valve mask. Once again, though, watch out for those pressures, high pressures in the airway. There's also some devices out there, some newer devices that provide positive pressure ventilations. They're automatic transport ventilators. You can adjust the ventilation rate and volume with these, and the provider needs to assure appropriate respiratory rate and volume for their patient's size and conditions are appropriate. So it requires a little bit more thinking as to how you want these ventilations delivered. And this is an automatic transport ventilator. This is a simple or basic one. Okay, so how would you decide between positive pressure delivery method to use for your, how should you decide which positive pressure delivery method to use for your patient? Well, it depends on how well the patient is breathing, what are their signs and symptoms, how much pressures are in the airway. If they already have pressures in the airway, you won't want a device that's going to increase the pressures, and whether or not the air is getting to the alveoli. Oxygen therapy. So there's some issues you need to consider when making decisions about giving oxygen. Oxygen is considered a drug, and it can cause harm, but it rarely does. But oxygen should be administered based on your overall evaluation of the patient's presentation and possible underlying conditions. Oxygen is portable. In the field, it's lightweight, it's safe, and it's dependable. And also it's installed inside the ambulance. These are some tanks, oxygen tanks. Be careful as a safety mechanism to lay the oxygen down in the horizontal position, because if they're upright, they can easily be knocked over. And if they're knocked over, they might become a projectile if it damages the tank in any way. These are larger cylinders that are used in the fixed systems in the ambulances, so they need to be replaced periodically. They come in various sizes. A D cylinder has about 350 liters of oxygen. An E cylinder has about 625, and an M cylinder has about 3,000 liters of oxygen. So, the M liter is going to last longer. This is probably the ones you'll find in the actual ambulances themselves. Incidentally, they all have measurements that go up to 2,000 psi or pressure. The G cylinder has about 5,300 liters and the H cylinder has about 6,900 liters. They use pressure gauges, regulators, and tubing that you use with oxygen. They use non-ferrous wrenches. You got to ensure that the valve seat inserts and gaskets are in good condition, otherwise you'll have leakages. And you want to use a medical grade oxygen. When you have an oxygen cylinder, you want to open the valve of the oxygen cylinder fully and then close it half a turn to prevent someone else from thinking the valve is closed and trying to force it open. Store the reserve oxygen cylinders in cool ventilated room, properly secured in place, and have oxygen cylinders hydrostatically tested every 5 years. Never drop a cylinder or let it fall against any object. Never leave an oxygen cylinder standing in the upright position without being secured. And never allow smoking around oxygen equipment in use. Never use oxygen equipment around an open flame. Never use grease, oil, or fat-based soaps on devices that will be attached to an oxygen supply cylinder. Never use adhesive tape on a cylinder. And never try to move an oxygen cylinder by dragging it or rolling it on its side or bottom. Connected to the oxygen cylinder are pressure regulators, and they help to provide a safe working pressure of 30 to 70 psi. Flow meters are what we use to adjust the rate that we deliver the oxygen. It allows control of the flow of oxygen in what we call liters per minute. Low pressure flow meters are pressure compensated flow meters and constant flow selector valves. High pressure flow meters would be able to hook up like the thumper to that CPR device, or would be able to hook up respirator and ventilators such as CPAP and BiPAP devices. And there's a low pressure flow meter and a pressure compensated flow meter that provides a constant flow selector valve. High pressure flow meter usually has a little connection to it that you can hook a hose up to, a hose of a device that will provide some additional pressure so that they can run. You hook up transport ventilators to these devices, or like it said before, the thumper. Humidifiers are connected to the flow meters sometimes to moisten the air. It provides moisture to dry oxygen from a supply cylinder. And this is how you would hook up a humidifier. Very seldom used in EMS. Some common hazards of oxygen and oxygen equipment. If the tank is punctured or a valve breaks off, the supply tank can become a missile. Oxygen supports combustion, so it can saturate towel sheets and clothing. Oxygen and oil do not mix under pressure. There's some rare medical situations of oxygen toxicity, or the air sacs can collapse. Infants can get eye damage, or you could have respiratory depression or respiratory arrest. So we're going to work with us, your instructors, and we're going to practice with some of this equipment in class and learn how to utilize it. So we'll have some hands-on skills of all of these different devices. A non-rebreather mask is the best way to deliver high concentrations of oxygen to a patient that's not having any problems getting air in and out. They just need a higher flow of oxygen. This is a non-rebreather mask. It's got round discs or flutter valves that allow the air to be exhaled by the patient so that they don't rebreathe their own CO2. And this is what it looks like. The bag needs to be filled before you put it on the patient. So you just cover it with your finger and fill it with oxygen. The tubing is connection to the oxygen tank, and then you put it on them. A non-rebreather mask provides oxygen concentrations of 80 to 100%. The optimum flow rate that you set it at is 12 to 15 liters per minute. There's a new design feature that allows for one emergency port in the mask to the patient and can still receive atmospheric air should the oxygen supply fail. Nasal cannula is usually the best choice for a patient who refuses to wear an oxygen mask or doesn't need a whole lot of oxygen. This is a nasal cannula. There's two little prongs that go into the nose, and then the tubing connects to the port on the oxygen tank regulator. So a nasal cannula provides oxygen concentrations between 24 and 44%. Oxygen is delivered to the patient by two prongs that rest in the patient's nose, and you set it at no more than 4 to 6 liters per minute. A partial non-rebreather is very similar to a non-rebreather, but there's no one-way valve in the opening to the reservoir bag. It delivers 40 to 60% oxygen, and you put it at 9 to 10 liters per minute. There's also something called a Venturi mask, commonly used in the hospital. It'll deliver more specific concentrations of oxygen. It mixes with oxygen and inhaled air. Some have a set percentage and flow rate, others have adjustable Venturi ports. And this is a Venturi mask. There's a tracheostomy mask. You can place it over the stoma or tracheostomy tube and provide supplemental oxygen. You connect that to 8 to 10 liters per minute of oxygen using a supply tubing that's provided. And this is a tracheostomy mask.
A non-rebreather mask provides the highest concentration of supplemental oxygen delivered in EMS. This mask is indicated for patients who exhibit any of the following signs or symptoms: cyanosis, cool, clammy skin, shortness of breath, chest pain, severe injuries, altered mental status, or a pulse oximetry reading below 90%. The device delivers oxygen by an attached reservoir bag or connected to the mask with a one-way valve. The valve prevents the patient's exhaled air from mixing with the oxygen in the reservoir area. The mask also has rubber washers that cover the exhalation ports. These washers allow air to escape on exhalation, but keeps oxygen continuously inside the mask. Should the oxygen supply fail, the design features an emergency port so that the patient can still take in atmospheric air. The liter flow for a non-rebreather should be between 12 and 15 liters. It should not be allowed to go below 12 liters. A non-rebreather mask will provide concentrations of oxygen ranging from 80 to 100% depending on liter flow. Here are the steps to follow in applying a non-rebreather mask. Take BSI precautions. Introduce yourself to the patient and explain the need for a non-rebreather mask. Attach the non-rebreather mask to the nipple of the oxygen regulator. Set the flow meter at 12 to 15 liters per minute. Allow the bag to fill completely. To inflate the reservoir bag, use your finger and the bag to cover the exhaust port or the connection between the mask and the reservoir. Position the mask over the patient's nose and mouth. Next, slip the elastic strap over the patient's head so that it rests above the patient's ear. Tighten the strap as needed. Watch the volume in the reservoir bag when the patient inhales from the mask. The bag should be at least half full. If this is not the case, the patient is over-breathing and you will need to increase the flow rate slightly. Most regulators will allow an increase in flow up to 25 liters per minute. Reassurance and encouragement will help reduce the claustrophobia sometimes associated with any oxygen mask. You might also have the patient hold the mask on his or her face, reducing claustrophobia even more.
Some special considerations. Facial injuries. This is going to cause some disruption of the movement of air because of the bleeding and swelling. It's going to change the features a little bit. You need to be aggressive in suctioning, and advanced airway maneuvers might even be required here. Some obstructions. This can impede ventilation of patients. If you're not able to ventilate, always consider the possibility that there might be an obstruction there. Dental appliances. Dentures should ordinarily be left in place when you do airway maintenance. Partial dentures may become dislodged, and then you can just take them out. Leave a partial denture in place if possible, but remove it if it endangers the airway. Hypoxia often occurs rapidly. Children burn oxygen faster than adults do, and that's accounted for by the many anatomical differences associated with the airway. Ventilating pediatric patients. Avoid excessive pressure and volume. Use properly sized face mask. Never use the flow-restricted oxygen-powered ventilation device or the demand valve. Use pediatric-sized equipment, masks, and nasal cannula. And gastric distension can impair adequate ventilation, so watch how much ventilation you're putting in there, because any extra is going to go into the stomach and cause gastric distension. Assisting with airway devices. Devices might require direct visualization of the glottic opening, such as endotracheal intubation. So when somebody intubates, then they need to visualize when they place the tube in. And you might be able to assist with this. Other devices are inserted blindly, meaning they don't have to look into the airway to insert the device, such as the King airway. It's a blind insertion. All right, so this is somebody getting intubated with an ET tube. They're doing what they call the burp maneuver, backward, upward, right pressure. So you press your thumb and index on either side of the throat over the cricoid cartilage, and you gently direct the throat or the trachea upward and towards the patient's right. Maximize oxygenation prior to the procedure when they're intubating. So make sure you're ventilating that patient really well. Position the patient in the sniffing position. Apply cricoid pressure, and then confirm placement once it's done, and then secure the tube in place. You cannot intubate somebody at the EMT level, but you can assist the paramedic. When the patient is intubated, you can ventilate them. Very little movement can actually displace that endotracheal tube. It needs to be secured in place. Pay attention to resistance to ventilations and if there's any changes and if they're difficult to bag or ventilate. If the patient is defibrillated, remove the bag from the tube and don't be touching the patient while they're being defibrillated. And watch for any changes in the patient's mental status. If it's a trauma intubation, provide manual inline stabilization throughout the entire procedure. Position your hands to hold that stabilization, but allow for movement of the jaw. The blind insertion airway devices are the King LT airway or the LMA. This doesn't require the head to be in the sniffing position.
Mrs. Johnson, take deep breaths. Just relax.
This is her last gas, sir.
Okay. Prepare to intubate. Mrs. Johnson, we're going to have to put the breathing tube down and put you on the breathing machine, okay? Okay, don't take your mask off. Leave the mask on. Lay back and take deep breaths, okay? Take deep breaths. Just relax. Take deep breaths. I'm going to give you some more oxygen, okay?
Okay.
Nice deep breaths. Can you give her 20 milligrams of etomidate and 60 milligrams of succinylcholine, please?
All right.
Deep breaths. You're doing fine. Nice deep breaths.
Sam?
Can we put the head of the bed down a little more, please? Deep breaths. Perfect. Perfect. Deep breaths. Okay. Can you back her for me, please?
Okay. She's still 100% SATs?
Very
Test
good.
the cuff of the endotracheal tube and the laryngoscope light.
Suction ready?
Hyperextend the client's neck to open the person's airway.
Okay, so she's oxygenating very well. Her sats are 100%. I'm going to prepare to intubate. Okay. Can you listen for breath sounds, please?
While another person is hyperinflating the client's lungs, you need to auscultate all lung fields to assess for ventilation.
Okay, there's color change. Can we call RT for a vent? And call for a stat portable chest x-ray, please?
I'm going to secure the tube now. I'm applying a tincture of benzoin. Have a tincture of benzoin.
Okay.
Move your hand, sir.
And then get an AC rate of 12, tidal volume 500, F5 to 100%, and a PEEP of 5.
Mark the tube at the level of the client's mouth and tape it securely.
Tube secure.
Okay, ready? Okay.
I'm going to restrain her arms just in case she wakes up.
Okay. She has an acceptable blood pressure. Can you cycle that cuff
Restraining
every
the
2
client
minutes
might
and
be
monitor
required
oxygen
to prevent the
saturation
client
closely,
from
please?
pulling out the
Yes.
tube. Check your agency's policy.
Even though intubation is not a skill of an EMT, there's plenty of opportunities to assist and help with that if a paramedic is going to intubate. Our chapter review. Respiratory failure is the result of inadequate breathing, breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest needs to receive artificial ventilations. Oxygen can be delivered to the non-breathing patient as a supplement or to artificial ventilation. Oxygen can also be administered as therapy to the breathing patient whose breathing is inadequate, or if they're cyanotic, cool and clammy, short of breath, suffering from chest pain, suffering severe injuries, or if they display an altered mental status. Always use proper personal protective equipment when managing an airway. Assessment of breathing must be an ongoing process. Respiratory status can change over time. Inadequate breathing requires immediate action. Positive pressure ventilations are very different than normal breathing and can have negative side effects. Select the most appropriate method of positive pressure ventilations based upon the needs of the individual. Always use appropriate safety measures when handling oxygen. Select the appropriate delivery device to provide supplemental oxygen. What are signs of respiratory distress? Well, they'll feel short of breath. You might see nasal flaring in kids. You might see retractions. Their breathing rate will be fast. What are the signs of respiratory failure? It turns into failure when they can no longer compensate, and you'll start seeing altered level of consciousness. Their vital signs will be low. They'll be cyanotic. For BVM ventilation, what are recommended variations in technique for 1 and 2 rescuers? Well, for a 1 rescuer, the preferred way is mouth to mask so that you can maintain that seal. If you got 2 rescuers, that's preferred over a 1 rescuer bag valve mask. How does the way positive pressure ventilation moves air differ from how the normal body moves air? Our bodies use negative pressure to kind of suck air in. We're delivering positive pressure and forcing it in against the body's natural tendency. Describe a patient problem that would benefit from administration of oxygen and explain how to decide what oxygen delivery device should be used. Well, somebody having a heart attack might need a little extra oxygen in their bloodstream to circulate to the tissues. That's just one example. Can you think of more? On arrival at the emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around the lips. Is she in respiratory distress or respiratory failure? Obviously, her body is no longer able to compensate. Her breathing rate is too slow. She's got an altered mental status and she's cyanotic. She is in respiratory failure, soon to be respiratory arrest. Is this patient in respiratory failure, and if so, what signs and symptoms indicate this? Does this patient require artificial ventilations? Yes, she does. She is no longer compensating. You need to take over ventilations and maybe you can bring her back, stabilize her a little bit.